All right. Well, hello to everyone, including those who are still joining us. Thank you so much for attending PPMD's webinar today, exploring the neuromuscular care, genetics, and the lived experience of Becker muscular dystrophy. And this is the first in our two-part webinar series this fall, focused specifically on Becker muscular dystrophy. Today, I am joined by two fantastic speakers and would like to take a moment to introduce all of us. So actually starting with the right hand picture and moving towards the left, Nevin Steiner lives with Becker muscular dystrophy. He is in his 40s, married with two kids, and works as a digital video producer. Nevin is an avid sports fan. Think Yankees, Jets, Knicks, Rangers. Loves to vacation with his family and cook and grill great food. Nevin's true progression of with BMD started in his mid 30s, and he has learned how to adapt along the way. He has made advocacy for the muscular dystrophy community a passion of his. The middle image, Dr. John Bransema is a neuromuscular child neurologist at Children's Hospital of Philadelphia. He has broad clinical and research interests in neuromuscular diseases, with a particular focus in clinical trials of novel therapies for childhood neuromuscular disorders. Outside of the hospital, he is a classically trained singer and musician, a budding Phillies fan, and helps his partner breed champion Lakeland Terriers. I'm Lauren Bogue. I am an employee of PPMD and a genetic counselor by training. I first became connected to PPMD while working as a genetic counselor in Duchenne Clinic at the University of Michigan many years ago. My primary role at PPMD is as curator for the Duchenne Registry, which is a patient-reported research program run by PPMD and open to all people with dystrophinopathy, that's Duchenne, Becker, carriers of these conditions. And I am based in Indianapolis, Indiana, with my spouse, children, and our lovable cat, Cardi C. Our session today is going to start by featuring each of us sharing information and insight on some of the topics that we know best. I will speak first about genetics and Becker. Dr. Bransema will focus on neuromuscular care in Becker muscular dystrophy, ranging from diagnosis through to treatment. And Nevin will explore his experiences living with Becker muscular dystrophy over time. And that's building his care team, adapting, and his advocacy. And at the end, we'll get to discuss the questions, some that many of you submitted in advance. And my understanding is that the chat is also open. Those questions come privately to us that we can also look at the end of the session. Well, I would love to kick us off with a conversation about genetics. I think depending on where you're at in your journey and experience with Becker muscular dystrophy, you have heard uh, spiels, so to speak, about genetics before. I'm hoping to give it, um, if not a little um, different of a framework, at least some new looking slides for you to look at, new types of graphics and diagrams. And one of the challenges I wanted to take seriously in considering it, how to present this topic was not to only keep the genetics at an arm's length, like here's our biology textbook over here, but to really consider how this is a personal experience and an emotional experience and stay grounded in that as well. So here are some foundations, sort of ground rules, a framework for how I like to think about genetics. And the way I consider genetics, whether that's Duchenne, Becker, other conditions, is that it is part of the story, but not the entire story. It can tell us some things, but not all things. And while to some extent it's a shared experience, right? There is a core commonality of genetics leading to Becker muscular dystrophy. And for this community, uh, that doesn't mean it's a universal experience as to how that affects someone, whether that is physically in their health condition, the symptoms they experience, or emotionally in terms of what that feels like for themselves and their family. And we do have to remember that genetics can have this rippling impact in a family. There are things about genetics that will be specific to the person, their care, their treatment, and yet this other cascade of things that can shape the emotional experience of that and the impact in a family. So, one of the topics I like to explore for Becker muscular dystrophy, because it's a question I get often, is how do we know what a specific genetic variant will do? which variants cause Becker? Does my variant cause Becker? If it is likely to cause Becker, or if we already know that that's what's going on for me or my family member, that can it tell us what's going to happen next? When are symptoms going to change? That is a common thread in a lot of questions I get. So I want to speak to what do we know about that? And for the things that we don't know about that, what are some of the reasons why we don't know? And just briefly, I want to start with how do we go from a gene to a person having muscular dystrophy? How is it that we get even different spectrum of muscular dystrophy, Duchenne and Becker, coming from the same gene? So you may have heard this before. Our body is roughly 20,000 genes in our DNA. I think of these like sets of instructions. They are all supposed to make something. And that something that each gene makes then has jobs to go do in the body. So the name of the gene that causes Duchenne and Becker muscular dystrophy is named DMD, and its role is to produce this molecule called dystrophin. Dystrophin, in turn, it's one of its jobs to do in our body is to provide stability in our muscle cells. So in when we have a typical set of DMD gene instructions, we can make the size, the structure, the amount of dystrophin that we need. And it is changes to those instructions that lead to a cascade where, okay, if our instructions don't allow us to make either the right amount or the right structure of dystrophin, that changes the stability of our muscles. That in turn causes inflammation, muscle breakdown, the cascade that takes us to symptoms of muscular dystrophy. So we know that it is changes in the instructions for this gene that ultimately cascade to muscular dystrophy. But there are so many different ways that the gene can be changed, right? That can be missing letters, that can be missing entire sections or extra sections of DNA, that can be differences in the way the sections of the gene are organized, the way they're stuck together, whether they are combined in ways that they shouldn't be, these pieces within the gene. And so not all genetic variants will have the same consequence. And that's like fundamental sort of first fork in the road where we have this difference between the pattern of symptoms we call Duchenne and a pattern that we are likely to call Becker is that there are genetic variants in this gene that are uh, that lead to no dystrophin being made or essentially zero dystrophin. And that's what leads to the pattern we refer to as Duchenne. There are also many types of variants that some dystrophin is being produced, some significantly reduced but not zero amount, some that may not have the same structure, the same ability to really do the job we need it to do, but that can influence this spectrum that we refer to as Becker muscular dystrophy. And I build towards that to say the next question people ask is, well, which variants are which? How do we know what they do? And this is where it gets um, a little muddier than we would like it to be and a little more uncertain than what we actually used to think it was. So it is true that there are categories of genetic variants in the gene that do trend with Becker, where we can look at a test report and say, okay, I see what type of variant this is. It is likely or leans towards a higher probability that it could be Becker versus Duchenne. And the way we arrived at that knowledge is that in the beginning, well, in the beginning of genetic testing existing, genetic testing was a confirmation test after we already had established that we really highly thought someone had muscular dystrophy and likely already had a suspicion of Duchenne or Becker. There were other tests being done. It may have been something that followed muscle biopsy that already told us about dystrophin being produced in the muscle or not. And so the genetic test often was an affirmation. Okay, someone has Becker muscular dystrophy. What are the types of variants we see for those people? And that's how we first learned about some of these categories. Here's a person who has symptoms that we have labeled a certain way. What do we find for them? That is how we found um, and identified that there is this category of variants that we refer to as in-frame variants that do trend towards um, manifesting as Becker muscular dystrophy. Now, this image you've probably seen before splattered about all these little boxes, all these little shapes. I want you to see this and think these are sections of the gene. The technical word is exon. What we learned as we tested individuals who fit a pattern and perhaps a muscle biopsy pattern of Becker muscular dystrophy was that variations in the gene, where yes, maybe there were some pieces missing of the gene, but that the pieces that were left on either side could still join together like puzzle pieces. Okay, yes, we're missing something, but the rest of the gene can still be connected. We recognize that those are the ones, as far as we knew, that trended best towards Becker muscular dystrophy. And we call those in-frame variants. You've probably heard that before. And so this developed as, okay, we see Becker muscular dystrophy, we see these types of variants, and our instinct, partially just as people, is to say, okay, we found these variants. They seem to go with people who have Becker muscular dystrophy. If we see those variants again, that's always what's going to happen. And the reality is that isn't true. We've learned this over time, partially because where in the process we do genetic testing evolves. So genetic testing now fits in an earlier part of the diagnostic process for most people, where we're using it to help uncover what things could happen and to get to that answer more efficiently. Um, but what that means is we can have someone in front of us. Albeit some people, we already think they could have Duchenne or Becker. We find a genetic variant that affirms whatever that is, it is consistent. But we also have people where we think we know what might be going on, and then we get a variant that surprises us or confuses us. And we say, oh, it actually isn't that that type of variant always does one thing or the other. There are exceptions. The other thing that is happening is we are starting to do more and more genetic testing for people who may not have symptoms yet. This is going to be true for newborn screening, where if there are infants with high CK on newborn screening, they will likely get genetic testing very early in life, and then we'll be looking at a genetic variant and will not have perfect information about exactly what that will mean. And so I say these things to honestly partially give validation to the experience that if you were given information, it's like we don't know exactly what's going to happen, we don't know exactly what this is going to mean coming down the road, that is can be upsetting, that can be frustrating. It is also valid because as you kind of notice in these images, the genetic testing is still going to be one piece that has to be added together with things that Dr. Bransma is going to talk about in the diagnostic process to actually arrive at what we should call the diagnosis. So this is the nuance of the, Becker genetics, is that there are variants that can explain what has happened. They can give us likelihoods of things to happen. They don't predict the future, usually. Now, another complexity that we deal with, both from a scientific level and an emotional level, thinking about Becker genetics, is genetic means potential to be inherited and run in the family. And in fact, we think when we see, let's say we're meeting the first person in a family who's had Becker muscular dystrophy, we think that variants that cause Becker are inherited 90% of the time, right? That most of the time there is going to be some other person in the family who at least has the variant, including if that's a mother who's a carrier. And so this experience of uncovering, does this um, have implications for how I plan to go about my reproductive planning? Do I have a lot of people that information has to be shared to in the family? Just a few? Am I connected to those people? There can be estrangements in family. That is an emotional process. And admittedly, there is also an emotional impact that we should acknowledge, that just the experience of this happened and this is or may be running in the family um, has an impact to people. Now, on a scientific level, and I could write it down and tell you a zillion times, there is nothing anyone does to cause or prevent a genetic variant or cause or prevent one from being passed on in a family, but that doesn't necessarily make us feel better as people or as parents. And so I want to validate that those are things that become part of our mental health needs is coping with the complexity of feelings that come with all these shades of things we think about when we're experiencing genetics and getting genetic test results. Now, I do always like to take a moment to just kind of explore a couple nuances about family history patterns for Becker muscular dystrophy. So, just be aware that the way Becker muscular dystrophy can look in a family can be really different from family to family. Very much so. There may be families where one person has Becker muscular dystrophy, and we assume their mother may be a carrier. We would test and find out, and maybe truly we don't identify the variant elsewhere. At some point, it was brand new, or it has been in a line of women, and we haven't seen symptoms for other people at that point. It is also true that it can look like there's only one person in a family with Becker, but it's because we don't always know all of our extended relatives. Um, that's normal. And we also sometimes have relatives where just other things happened to them before we really understood whether they would have developed symptoms. I always caution people beware of sentences you get from family members that are like, well, I was told so and so couldn't have been a carrier or couldn't have been affected because XYZ. Now, sometimes that XYZ is valid, but always have that little bit of moment to get some support to figure that out if you hear sentences like that. Ultimately, um, genetics is healthcare. This is why we have to have genetics embedded in our healthcare is to connect all these little dots, figure out all these little nuances. And I do just want to kind of reconnect and bring back home that the spectrum of experiences really has no limit. If you have experience getting a test result and it actually was a relief to know a diagnosis, that's valid. If it was surprising, upsetting, those are also valid feelings. The feelings of this is going to matter for how I have children versus not, both both are normal and valid. Um, and so thinking about the ways in which you're experiencing a condition, not only from a like physical health perspective, but emotionally warrants healthcare. And I do want you to know that you deserve genetic counseling. Now, genetic counseling is not always necessarily has to be provided by genetic counselors. I bet Dr. Bransma does tons of genetic counseling. Neuromuscular specialists usually do. Genetic counselors, of course, do. And then frequently, even we need support from obstetrics or fertility, reproductive genetics to fill in some of those gaps. So you deserve this as part of your healthcare to have your questions answered, to feel affirmed in the choices you're making, and to feel like you have been given the tools you need to understand your genetics as best as possible. So that's my little genetic spiel. And I am going to turn it over to Dr. Bransema to explore neuromuscular care.
Hello, everyone. It's such a pleasure to be here with you today, and I really appreciate the invitation from the PPMD team to share some thoughts on diagnosis and neuromuscular care in Becker. We can go to the next slide, please. We like to think of each disease in this area as distinct. So I'm not trying to lump things together by showing this slide, but I do want to make the point that people living with a dystrophin mutation can have highly variable experience of what that actually means. And so we have our more severe end of the spectrum with Duchenne, but Becker would also be considered one of the more severe. There are people who only have cramping in their muscles or are asymptomatic and still have a dystrophin change. So it's very important to think about what you're presenting with in terms of your symptoms, what we might call the phenotype, and not just get anchored on what Lauren has already described, which is the genotype of having a change in this very large gene in the body. We can now go to the next slide. When we think of Becker, what we're defining that as is not consistent in the literature, but usually tends to mean retaining the ability to walk past your 16th birthday. If you lose the ability to walk before the age of 16, most people would call that Duchenne, although there is an intermediate category that goes from about 12 to 16 years of age, which doesn't clearly fit into the one or the other definition. And these are truly ways to define boundaries for both what we tend to try to work on in terms of research in this area, but also understanding clinically what might be needed in terms of the care. The typical Becker experience is to start with your symptoms around 8 to 13 years of age, but there are people who don't have symptoms until they are well into adulthood with Becker. It would be about 90% that have some symptoms of limb weakness over the age of 20. Walking problems are usually in the mid-teens, and these are progressive, but quite slowly progressive for most people over time. And we need to remember that the heart is a very important muscle in the body, and that it does not necessarily match your level of limb weakness, what you're experiencing in terms of your heart weakness. So this is why surveillance of the heart is so critically important in Becker care. We can go to the next slide, please. Common symptoms that would be noted are issues with the proximal parts of the limb. So this would be things like getting up from the ground, going up the stairs, and in the arms, raising them up above head level to reach for a shelf or to shampoo the hair. Um, Without intervention, ambulation beyond the age of 16 years is usually typical. And toe walking can be an early sign also in people if they tend to be up on their toes while they're ambulating. Some people may notice also a curvature of the lower spine where it tends to kind of jut out a little bit as people are walking. That's a compensation measure that happens when you have truncal weakness in this disorder. People may notice that their calves muscles are quite large relative to the other muscles in their leg. And eventually, maybe that their proximal part of their leg might be atrophied or smaller. And then the heart symptoms, if you're experiencing them, would be more things like shortness of breath with exertion, skipping beats of your heart rate that you can appreciate, or pain in the chest. The pulmonary involvement is usually minimal at first in this disease, but can become an issue for those who are no longer walking. So it is important to keep vigilance of pulmonary function, but it is not as big of a concern as it is in Duchenne. And next slide. So most people will be diagnosed based on symptoms of motor issues, loss of limb strength over time, but there are people who come into our clinic other ways. One thing that many of you who are living with dystrophinopathy might have had tested as part of your diagnostic workup is a creatine kinase level, or CK. There are some situations where that might get tested in people who don't have symptoms of muscle weakness, and what we tend to see more commonly is these other liver-related tests called AST and ALT, are called liver enzymes by a lot of people, but they actually come from many tissues of the body, and that includes the muscle. So in people who have muscular dystrophy, you can have an elevated level of AST and ALT, which can be caught on lab work that people are doing if you have a viral infection or some other reason why you might seek care. And it's important in that situation to check the CK because that's usually where the specialist will then realize that a neurologist needs to be involved. We see some people, unfortunately, get to the point of having liver biopsies because people are trying to understand why these liver tests, quote unquote, are elevated when in fact it is a muscle issue that's leading to the problem. Next slide. And so when we're trying to diagnose this in the clinic, of course, history and physical are very important. We talked about the CK, and aldolase is another measure of muscle damage that can sometimes be done. We rarely need to do a muscle biopsy in diagnosing any longer, but there are situations where it can still be helpful if there is uncertainty about variants or if somebody has a very rare dystrophin change that isn't picked up by the standard genetic testing. We can do imaging of the muscles. We can do a test called an EMG, which is a look at how the muscle and nerve function electrophysiologically. But again, most of the hallmark of coming to this diagnosis nowadays is through genetic testing. And then next slide. So ways we meet people besides the elevation of the CK, AST, ALT that gets them through our clinic is that some people have a microarray test done nowadays if they're delayed in their development in general. And we do see central nervous system involvement in some people with dystrophinopathy, which I'll get into in a later slide. But if you do a microarray, you can pick up a dystrophin mutation, especially since most of them are deletions. And so that might be a reason for referral before the motor component of what's going on is appreciated well. And then Lauren had also brought up the concept of newborn screening, which is starting to gain momentum in this country. A few states have pilot programs, and they're doing this based on the creatine kinase level. And so the level of elevation of the CK becomes important in terms of whether people will be detected this way and also trying to think about how severe their dystrophin mutation may be based on the degree of elevation. Next slide. So when you end up in the neuromuscular clinic, what we try to think of ourselves as is the medical home for people living with muscular dystrophy. And many of our families, I hope, perceive us that way because we try to really coordinate all of the aspects of care that somebody might need. It's usually a neurologist who does this, but in some areas of the country, you may have a physical medicine specialist who is leading the muscular dystrophy clinic, or in some rare cases, someone else like a pulmonologist or an orthopedic surgeon I've even seen in some contexts. The point is somebody who really takes the ownership of this and really tries to ensure that people are getting the comprehensive care that they need. And so we'll be monitoring disease progression and guiding treatment considerations, thinking about different referrals that we might need to make for optimizing care. We partner a lot with physical and occupational therapy in our clinics because exercise and quality of life and function is a really important aspect of living with muscular dystrophy. And some people may need orthoses or other equipment for augmenting ambulation or other aspects of ensuring that they have as much engagement as they can with their school life in our phase of the world, with the community, with their work life as they become adults. And we also talk about research trial opportunities at every visit with all of our patients at our center because there's a lot going on right now, and it's confusing to navigate for anybody trying to decide what the right combination of opportunities might be for them or their child or their person that they care about that lives with Becker. So we're the leaders of the multidisciplinary team, but if we go to the next slide, you can see that it really does take a huge number of individuals to help. And I apologize that this is a figure designed for Duchenne muscular dystrophy, but there really is a lot of overlap in terms of the care needs that might come up and the people that you might need to be having involved in your care. We've touched on a lot of these already. The pulmonologist with screening for pulmonary issues, very, very important to get regular cardiac screening and ensure that if you need medications for your heart, that those are being considered. But one area that we sometimes don't talk about as much in these contexts is the CNS and psychosocial aspect of living with dystrophinopathy. And this is not everybody's story. There are many people who have entirely normal cognitive function and no behavioral concerns, but there is a significant proportion of people living with dystrophinopathy that do have these issues because dystrophin is also expressed in the brain. And if you are deficient in dystrophin, your brain is not 100% normal in terms of how it functions with its neurotransmitters. This can lead to issues, especially with attention deficit hyperactivity. Also, anxiety is quite common, and depression can be more common also in people living with dystrophinopathy than the general population. So all of these things are important to be aware of, and there is a sub-portion of people living with Becker who have autism spectrum disorder, and that's very important to identify if that is part of your story because you often need more resources to ensure that you're functioning effectively if you're living with autism. If we go to the next slide. We want to screen for this at least annually in the clinic, these different issues that may come up. Remembering also that caregivers involved in the lives of people with Becker sometimes also have some of these concerns come up over the trajectory of living with the disease. So there are some key stress points for some people that we need to be aware of, such as the initial diagnosis. The time when you lose ambulation can sometimes be a big transition for people to process. Ending school and figuring out a life of post secondary. What are you going to do, college or work, or is there other things that you're looking to explore to do as an adult? And sometimes the first hospitalization can also be a stressful time. The resources for this are hugely variable across the country, but we want to try to remember to screen for this and to get people the appropriate resources, whether it be therapy, whether it be a psychiatrist, other resources that may help with living with this aspect of dystrophinopathy. And next slide. So the last slide here is just about some of the potential treatments for Becker muscular dystrophy, because right now our standard of care is multidisciplinary management, and we don't have targeted treatments to offer at this juncture, but there are many research trials that are being worked on in muscular dystrophy, and there are some specific to Becker to be aware of. In some of our patients that we meet in the pediatric clinic with Becker, we do consider corticosteroid treatment if someone has a more severe weakness course. And so it is possible to be on steroid treatment with Becker, but it's not common. Most people are not. There is a new steroid called vamorolone, which has a different side effect profile than the traditional corticosteroids do. That may also become a consideration for Becker, and there are trials looking at this. Sevasemten is a modulator of muscle contraction that's being studied. There have been early data presented at recent meetings of our community, but no papers yet about this compound in people because the trials are still ongoing. So we're still awaiting the full profile of what is learned about this compound, but so far it does seem to have a measurable signal in terms of impact on the progression of weakness being slower and also being very well tolerated in terms of safety. Givinostat is a histone modulator that was studied in Becker and unfortunately did not show the same signal that it did in people living with Duchenne muscular dystrophy, but there's more work being done on whether there's particular types of people with Becker that might potentially benefit from givinostat treatment. And then the genetically targeted therapies are a huge and very complicated topic because so far our forays into this have not been hugely successful in the Duchenne community. Unfortunately, the impact in terms of efficacy has not been what was hoped for in the first generation of exon skipping treatments. And we do have a gene transfer therapy available for severe Duchenne presentation that has still a lot of learning to do about the efficacy and also how durable it is, how long it lasts, with some significant safety concerns also coming up around that treatment. So the bottom line is there is no genetically targeted treatment approved for Becker right now, but as new iterations of both the exon skipping RNA-based approaches and also the gene targeted approaches, whether it be a transfer of a gene, editing of a gene, anything to try to change the underlying genetic issue that we're dealing with in dystrophin. These may come available for people living across the spectrum of dystrophin severity over time. And I think that is everything I had to say. Just go to the next slide to be sure. Yes, I will now transition it over to Mr. Steiner to hear about living with Becker muscular dystrophy.
Thank you, John. So first, I want to start with a disclaimer off the top. A lot of times there's a stigma out there that Becker muscular dystrophy is the lucky one to have versus having Duchenne. And what I'd like everyone to know is no, that's not the case. Having Becker also bluntly sucks. It's not a fun disease, but I have made my life a positive life. I have made living with Becker a superpower of mine, something that the community and myself We can benefit together to grow and learn, and have a place where we're working together to better this disease. Next slide. So these are a few pictures of me, but I'm going to start from the beginning. I'm going to be brief as possible. I was diagnosed at the age of 6. I'm 42, though that was in the 80s. And my parents went to all the doctors because I had trouble walking long distance. I developed the ability to walk late. I never crawled. Um, so they noticed that something just wasn't right. But after diagnosis, it was always, you have Becker muscular dystrophy and you are going to live a full, positive life and do everything that you can to stay as active as possible. I played all sorts of sports growing up. I wasn't very good, but I still played. I ended up playing varsity tennis in high school and I became a cyclist. Um, and I was able to bike, anywhere from 40 to 70 miles. I was doing it for charity in New Hampshire. There was a bike ride for the MDA, so why not do something positive for this disease that I live with? The neurologist at the time said to me, maybe you should just go on the trail for 10 miles and that'll be fine. And I said, no, I can do 70 miles and I'm going to do 70 miles and you're not going to stop me. And a lot of people, even in the chat today, said, are there any no's, things that we shouldn't do? I think the most important thing is making sure that your child and as an adult, you live a full life and you don't stop doing anything because we don't know what the trajectory of this disease looks like. It's different for everyone. We don't know what causes the breakdown. We don't know what causes increased progression. It's unknown. So you have to live your life. The physical therapist at the time, I met her down the road after I couldn't do that bike ride anymore. And she said to me, did you enjoy the bike ride? I said, yes. Then you lived your life and that's all that matters. So now as my disease has progressed, as you can see, I am married and I have 2 kids. Um, we live a full life. We vacation a lot. We go to sporting events. You can see Yankee Stadium right there. In the middle, I'm speaking at the Parent Project conference back in Vegas. So, I have the scooter there. I'm still able to walk. I use a rollator. I want to be safe when I'm out there. And, at a young age, I learned about preventative care. We can go to the next slide. So a lot of people will say they wish they knew back then what they know now. And that's very true. My parents just taught me from a young age, we're gonna be proactive. And I'm gonna talk to you about my current care team. I have a primary care physician. He does not know everything about Becker muscular dystrophy, but he knows how to tell me the right things to ask, tell me the right things to do, point me in the right direction. I have a neurologist that I see, and I still see a pediatric neurologist. Some pediatric neurologists still see adults. Um, and I've changed my neurologist over time for a variety of reasons. Listening to what I need. Sometimes the neurologist decides to go to a different practice, and I'm not able to get there. I've had a cardiologist. I had the same one from the age of 15 to about 35, and then he retired. And at first, I probably don't know why I'm there when I'm 15 years old. I just went along with it, and this is what I was supposed to do. When I was about 23, he saw some cardiac function that didn't look right. He put me on medication. As I've told people in the past, going to college, living that life, that could have impacted it a little bit. He eventually retired, and I said, okay, let me go somewhere closer because he was 2 hours away. So I went somewhere closer, and I had the first visit, and the doctor said to me, why are you here? And immediately I said to myself, well, if you don't know why I'm here, I'm going to go back to the other hospital where there was another doctor ready to see me because they understood I am here because I need to make sure my heart is functioning correctly before something bad happens. And I was not going to stay at a cardiologist that didn't understand that. Also, the pulmonologist that was recommended from the neurologist. And the pulmonologist, the cardiologist, and the neurologist all know so much about Becker muscular dystrophy. The team that I put together has an awareness. And the pulmonologist, again, there's nothing wrong with my lungs right now, but they want me there before something bad happens. So I go there once a year. Physical therapy and occupational therapy. Um, I have a physical therapist. I do aquatic physical therapy, occupational therapy. I've done here and there. It's not consistent. I had a hip fracture back in April, and I went to rehab, and I had physical therapy and occupational therapy. One of the things that I've learned along the way is to advocate for myself. The doctors, after they did the surgery, said, "No, you're going to go home and have home care." And I said to myself, and I didn't ask everyone around me for opinions because my opinion is the most important thing. I said to myself, if I go home, I don't think I'm going to walk ever again. I think I can see this not going very well. Send me to rehab. I never questioned it. I went there and they saw someone who had a hip fracture, but also had muscular dystrophy. And what can we do to get you stronger? Physical therapy and the occupational therapy, working on your upper body. Sometimes we forget about that. My upper body isn't always great. My hand strength isn't always great. Physical therapy, we know the stretching, the walking, the biking, all that stuff is really important, regardless of an injury or just, staying up with your maintenance. And one of the things I really like about occupational therapy is adaptive equipment and seeing how you can make your life better. With all of this, there's also the mental health professional. There's days where this isn't fun, and you can have stretches where it's not fun and you need someone to talk to. I also have a gastroenterologist. Your stomach health with Becker, I've been told, is a thing. So I have that if I need it. So the primary care, the neurologist, the cardiologist, and the pulmonologist, physical therapist are all the time. The other professionals, as need be, but I want them as part of my care team. And I've built this care team myself based off of, the needs that I've been told that I have to address, and also based on the doctors that I like. If I don't like a doctor or I think I need something else, I'm going to go somewhere else. Next slide. So part of my adaptive journey is adaptive equipment. At first, I was a little bit hesitant on a lot of this stuff, but then I was like, what's the reason for that? There is no reason. I was using, a walking stick for a while, and last year around this time, I came to the realization that that's not enough. My balance isn't great. Let's try a rollator. I also had a scooter at that time that we got for long distance. You know, my wife, my family, they don't want me wearing myself out. The doctors don't want me wearing myself out. So if I'm at a sporting event, or if I am at an airport, why waste it? Why ruin my energy? So I have the scooter. The rollator is fantastic. I was so afraid to get it. A lot of people that I'm friends with on the pack uh, that have Duchenne, they're like, "What are you doing? Just get it." I've got a seat. I've got four wheels. I've got handlebars. I'm not going to fall. My balance isn't great. It's amazing. I also, when I injured myself, I got a ramp in the garage, and I was like, all right, let's see what's out there. And it takes a little work to find these resources. So someone came out and they said, well, we have a platform lift used that you could have. All right, I was looking at those and they're $30,000. I know $5,000 is still expensive, but now in my garage, if I don't want to use the stairs, because I barely use stairs, I do have a staircase that's only 3 stairs, and I am able still to do that. There's a platform lift, so I can roll right in, push the button up, and go to my back porch and enter the house. And I don't fully need that now, but as I've always been, I'm proactive. I'm setting myself up for the future. I have a walk-in shower. I have a raised toilet with a bidet. Uh, some at first were like, why do you need that? Well, when you lose hand function, you want to be able to clean yourself nicely. And it's become one of the greatest things that I've ever got. I have a lift recliner, which I'm sitting in right now. I decided to do that before I fractured my hip. So, getting up from seats, not very easy. I recently, took a train to the Becker Education and Engagement Day. And on the train, I'm very capable of asking for help because I can't get out of the seat, so someone has to help lift me a little bit. So at home, I just push the button and away I go. And I also have an adjustable bed to help me up. So I've put this equipment into my life for a reason. Next slide. So you'll see some of the things here, the lift in the garage, my rollator. People have commented that the walking is better. Using the walking sticks, I still felt uneasy. The raised toilet and the walk-in shower. Next slide. So this journey has come with advocacy as well. And I was asked at the BEAD conference, how do you get your kids involved? And the first thing I said is, don't hide behind the disease. I was able to hide behind the disease for a long time because it wasn't visible until about 2020 when it became really visible. And, you also have to teach your children to advocate for themselves at appointments with care providers, speak up for what they need, because when they turn 18, it's not your job anymore. It's their job, and they need to be comfortable with it. I don't want, someone asking, well, when do you tell them? Right when I was 6 years old, my parents were like, all right, we're going to go to physical therapy and we're going to go to the neurologist and we're going to go to the doctor. And I'm like, all right, that sounds great. Uh, they made it fun. Like we would go to sporting events, we would go to restaurants, we would do things when we were traveling because we traveled to appointments because that's just what you did. You travel for the best doctors because you're not always going to have the best doctors in your area. When I became comfortable with my disease because it was visible, I joined advocacy groups. I joined the PAC, PPMD's Adult Advisory Committee. I also, did things with the MDA. They have a mentorship program, mentoring younger kids that have this disease. And that's one of my favorite things, giving people hope for the future. I attend all the conferences and I speak up. I speak up to the point where I just get emails, hey, we're doing a webinar. Can you be involved? Sure. Because that's the only way we get better and break down the stigma that we have to live with this disease and we really don't have a choice. So let's make the best of it. I'm proactive. I'm happy I have this disease because I don't think I'd be the same. Do I enjoy it? Absolutely not. But I've made the best of it, and that's all we can do. You have to remember too that you might have Becker, but we can help the entire neuromuscular disease community. I reach out to people with limb-girdle, SMA, Duchenne. Like we're all a resource for one another, and build a presence on social media. Until 3 years ago, I had never met someone with Becker, but had I talked to them on social media, DM them, ask them questions, how are you doing with this? How are you doing with that? Figure out how we do this together. And there's a community of people that I have that I've never seen before, or that I see very minimal, but I can just, message them on my phone and, have some conversations about this. That is where my journey's at. Um, will it stay the same? We don't know. The future of medicine, it's all TBD. I am, participating in trials and studies to, help with the future for myself and for others.
Thank you so much, Nevin and Dr. Bransema, for sharing all your knowledge and insight. And we now get to, I'm going to stop sharing the screen so you can just see our faces. We now get to think through some of the questions that have come through before the session and during the chat. And so I'll field those out to Nevin and Dr. Bransema. And actually, very simple, short and sweet question to you, Nevin, off the bat. Has Becker muscular dystrophy affected your driving? But how are you adapting to that?
I'm still driving. I will tell you, probably 5 years ago, I could go 4 hours without stopping, and now it's more like an hour and a half because sometimes my feet cramp up. But I am still driving. I am still, very independent. The rollator that I have is only 10 pounds, so I can get it in and out of the back seat. And when I'm with my, friends, family, kids, like put the rollator in and away we go. I take all the help that I can get.
And another question for you in the sense of advocacy. You have given a lot of thoughtful perspectives on why you do it and how you've been involved. If someone was looking to really start that journey, I think I heard you kind of echo social media, right? You can start there, being out there. Are there other like first things? Like this would be a good little easy place to start if someone was just starting on their advocacy journey.
The if you go on the Parent Project website, not only is there the pack, which is young adults and older adults. I'm considered one of the older adults. Um, there are also tween groups that meet on the weekends for socials to connect with other people with this disease. That's a good place to start. There's Discords. A lot of kids play video games. There's also once you get into the pack, we do fantasy leagues. So there's a lot of opportunities. If you go on the Parent Project website, you can find out more.
Great. Thank you for that. And now I have a couple care related questions for Dr. Bransma, and they seem to be coming in two themes. I think the first set is on the theme of what to make of scenarios that don't match our traditional definitions for Becker or expectations and how you adjust care over time with people. So there was an example given about a mother offered her insight that she has sons who were always told the condition was Duchenne. They're still walking much better than had been expected as they enter their early teen years at 12, just normal ambulation. How do you talk to those situations with families?
I think this is one of the challenges we have in the clinic for sure, that there's the extremes, which are more obvious. You know, if somebody is very mild and comes to an adult clinic with symptoms, we know that they have Becker muscular dystrophy because they've lived up to that point without issues. Whereas somebody who is very, very early with their weakness and their CK level is very high and they have a genotype that's supportive, we can be quite sure about Duchenne. But we're never perfect, you know, and I think we learn this over and over again in collaborations where people with the same gene change do not look like each other when you start to compare people from different centers. I have families where two brothers will be very different from each other, even though they have the same gene change. They have a different level of cognitive involvement, they have a different level of skeletal muscle involvement, a different heart involvement. I think we have to be humble about understanding that we're not perfect in predicting, adjust as we learn new things about how the trajectory is going. And this is why I just really encourage people to be linked with a Duchenne care team. Like you need to be with a clinic that feels comfortable, or with the Becker care team, excuse me, because if you're seeing somebody who doesn't have a lot of familiarity with Becker muscular dystrophy, I think they can easily get kind of lost in the weeds of some of this stuff and lose the perspective of what actually needs to happen to optimize outcomes in care.
Can I chime in real quick? One of the reasons why I left one of the practices I was at is because it was a multidisciplinary practice. So they were seeing a lot of diseases. And when I went to where I am now, UMass in Worcester, it was specific to Becker and Duchenne. So the care that you get for Becker and Duchenne is very similar. It's just the trajectory of where you are, the progression is different. But the doctor, being pediatrics, said to me, "Is it okay if I treat you like the Duchenne boys?" And I tell them I look under the hood and I check everything out like a car mechanic, and I'm just like, "Go right ahead, tell me everything I need to do." But at the same time, I'm still telling them, "Hey, I want to try the rollator, or I want to get a scooter, or I want to try aquatic therapy." I still need to advocate for myself.
And then a similar line of thinking about just situations and maybe how we weigh things in the diagnosis. We were also given an example of a situation where a muscle biopsy is actually showing some amount of dystrophin, and that led to a Becker diagnosis. There's also, however, a CK that's extraordinarily high, 60,000 plus for an individual. And of course, I'm sure there's clinical history and genetic history. Are there factors that override each other or weigh in differently for you in your diagnosis process?
I think each piece of information is supportive, but you have to put everything together to make the picture. And if you get anchored on one piece, I think that's where you can go awry. You know, so Someone can make dystrophin. It can be where we want it to be in the muscle when we look at it on a biopsy, but it may not be functional. Like it's there, but it's not doing its job because it doesn't connect properly with other proteins or something about it is faulty. And so muscle biopsy is not perfect either at predicting what the overall experience is going to be for somebody with their dystrophin change. I would be worried about a CK level that high. I certainly would be watching very closely for whether there's functional changes that would make me more concerned it was going to be severe, even if the genotype that had been determined in that situation might be more suggestive of a Becker experience for other people who have been described. But I have patients with muscular dystrophy who have quite high CK levels and look great when you see them in the clinic in terms of their function. So again, a CK level is not a perfect test either. It's all putting it together to make sure that you're doing reasonable things at the reasonable time for the person. We don't want to over investigate someone and ask them to do things that aren't necessary, but we also want to make sure that we're not missing something that we could be helping with. Yeah.
One thing I will add to that from a almost like a coaching perspective to I think people out there who have these types of questions is a genetic counselor doesn't get to have a medical opinion, but I do sometimes feel like our role is to like coach for like how to get the medical opinion verbalized from your physician. I always say to people, I think our doctors have they have all the reasons. They have reasons for why they told you the thing, but it's okay to ask for, hey, I saw this, this, and this why did we arrive at this point, and are there reasons why we would shift a diagnosis perspective at some point? Reasonable questions to ask. Now, our other sort of theme for questions, and hopefully it's okay for Nevin and Dr. Bransma for us to carry over just a little bit. Our other theme for questions is about, of course, care. And we had several questions along the theme of physical activity and both doing that and tools for maximizing our physical activity and just are there lines in the sand for like this is potentially increasing damage and we shouldn't do it or we'd recommend against a certain type of physical activity? By we, I mean neuromuscular care.
We really try to partner with our therapists on having this discussion with patients. So I would just say that there's no one size fits all approach to what the right amount of exercise is. It's very much about respecting what your body is telling you. And so if you feel totally wiped out for 2 days after you tried to do something and you're sore and you can't do what you usually did, that was probably too much, is what we tell people, and it's usually around the same amount of gas that you have in your tank each day, but it's not perfect. Some days you might be a little bit more able to do things than others. We also used to say no weightlifting, but actually there is some literature that some people with muscular dystrophy that actually does benefit to do some light weightlifting over time. And so everyone is learning about this together. I just think the main thing is respecting warning signs from your body that if you're in a lot of pain, you're probably needing to talk to someone about how to move more effectively and more safely for your body.
I find that sitting and not doing anything is worse than doing something. Uh, but listening to my body, swimming, stretching, uh, cycling inside. I have a couple of different things. I have a Peloton and one of those foot pedals that you can do just sitting at a desk or in a chair. But I also tell people when we hear from physical therapists and occupational therapists, sometimes my physical activity is going to the grocery store. Sometimes it's the 5 errands that I do with my kids, and then I have to tell myself I did enough today, and I should be happy that I was able to do those 5 things with my kids and not worry about it because you don't want to overdo it.
And maybe a question that isn't possible to answer, but Dr. Bransmo, we've gotten some questions about sevasemten, and I heard you kind of signal like we don't have a lot of data yet. Do you have a sense of when we could expect more information or news about that product?
Um, it, Drug development is really complicated because the timelines sometimes change if something new comes up that you're not expecting, or there may be a regulatory thing. So I always hesitate to say in 6 months you're going to hear this because we learn over and over again that that's not the reality. But I would say that it's quite far along and that there is some data along. So I would expect if everything goes well that we'll get readouts this coming year for what is going on in the development program. And they're studying it across the dystrophinopathy spectrum, including adults with Becker and also children with Duchenne and some teenagers with Becker. So I think that there's a possibility that it could be applicable to a lot of lives with dystrophinopathy if the data is encouraging. It's just, I think it's too early to say that now because we don't have the results from the trial yet. So it's a possibility.
And my inside information, I know nothing. I'm not on anything. Is that they've closed a lot of enrollment for a reason because they have hopefully all the data they need. But as John said, we just never know because things can come up that can change the course of how they're going to do this.
And I think maybe one last question, if the two of you have a moment. One thing that I get approached with sometimes is conversations where I happen to be talking to a family or adults affected by Becker muscular dystrophy, and I will hear comments like, "Well, there's nothing. We stopped going to clinic because there wasn't an offer of steroids. There wasn't an offer of any of those things." What would be your thoughts on how is it worth reseeking care, and is there still a role for neuromuscular care for those people who kind of feel lost? Has that mindset changed?
I mean, I come to work because I think I do something important when I'm there. So I hope I'm helping people with what I do in the clinic. But I will say that when we see the people back that have been away for a while, all sorts of things tend to come up that are issues that we might have been able to get ahead of or maybe modulate. And so we just learn this over and over again that it's not good to come back when you're already in trouble and something new is going on that you need help with. It's better to have that kind of consistency of follow-up that allows us to anticipate these things and work through them in a way that's much less challenging. And a great example would be not being aware of your function and having an injury where you have a fracture or something like that. We couldn't sometimes avoid something like that happening if we're more ahead of the game. And that can be a big changing point for someone's function is if they have a big fracture like that. So I would just encourage coming to see us. We like seeing you, and it is helpful, I think, to have those regular check-ins about your care. Plus, there's always new things going on, and while we don't have that thing to offer right now that's Becker specific, I think there's lots of ways that we can still be helpful to make sure quality of life is optimized.
I think preventative care is the story of the game. I didn't know at a young age why I was doing it. I just went along with it and then just became my life. I was just going to find the best doctors and the best care, and I want to be in front of everything. And one thing, if you end up traveling to a neurologist, maybe once a year for clinic visits, you can still have someone locally by just in case you have a question or a quick follow up that you want to go and get their opinion on. I have some of those doctors as well if I need them in my back pocket. So a lot of resources for the just in case and the unknown.
Wonderful. Well, with that, there are always more conversations and so many interesting things to talk about. And so apologies if we didn't get all questions exactly. Hopefully you're seeing, the final slide here just to say thank you to everyone and to kind of signal that even if we're wrapping up a session today, we want to be a resource for you as PPMD. Of course, there is a second part to this webinar a webinar series coming in November that will focus on cardiopulmonary care. But we also have available, the ability to just sign up if you live in the US to sign up for a time to be like, hi, I'm trying to figure out where I should even consider going for care. Hi, I have this question about like, is this genetic thing? Does this make sense? Um, we're here for those questions. I hope individuals with Becker and Duchenne and people who are carriers will consider joining the registry. That's how one of the ways that we learn more and that everyone can contribute to data. And please know that we have support materials, including like emergency care items that are universal across the Duchenne Becker spectrum that are available to order. Let us know how we can support you, and we hope you have a fantastic rest of your day.